Hi everyone, this is Neel Raithatha, consultant, audiologist and director of iCLEARscope. Thank you for joining me in my latest video using the iCLEARscope endoscope. And here we have a patient who attends quite regularly. Let's have a look. I'm just looking at clinical notes. It's every 4 months, believe it or not. And they do have chronic fungal infection, otomycosis, and they've been seen by ENT, their GP, and various swabs, various medications, and unfortunately, they for some unknown reason they just can't get on top of it. Now I'm not a medical doctor, so it's kind of not something I can deal with myself, and I'm sure if ENT can't deal with it, I'm not going to be able to deal with it. And the patient has also been seen by dermatology as well. And what dermatology have done is prescribe some topical steroid cream, and that's more for the pinna, the auricle, the cartilage on the outside of the ear, so the satellite dish, because that's also somewhat inflamed. I think they previously had perichondriitis, so it's the perichondrium, which is a thin film of tissue that lines the cartilage, and that's become inflamed, and typically can happen due to trauma. So people who box, for example, or I think in America they call it wrestler's ear. Here we call it cauliflower ear. So typically it's a combat sports where rugby players, for example. But I think with this patient it's more just a chronic infection, and that seems to have helped definitely. So ENT, I just advised that they have their ears clean on a regular basis, which the patient is happy to do. So it's kind of 3 times a year they have to come. This is the better ear of the two, actually. The entrance of both ears is quite narrow. Once you get in there, it's a decent size. You can see the consistency. It's a horrible, sticky, stretchy consistency. The right side, it was a bit more mushy, and it was actually all over their eardrum as well. So I got the majority out. There's only so much you can remove. So with the right side, if I went any further with that, it's a risk of causing trauma to the eardrum, because I was literally suctioning. The suction tip was on the eardrum, and some of the debris just wasn't coming away, but they could hear 100% on that side post-procedure. So I'm just trying to peel this off the anterior canal walls. There's a thin layer of skin there that's attached to the debris, the mushy wax. It's just blocking the suction probe. Of course, you can't irrigate this ear. You can't use any water in there, because that can exacerbate the patient's symptoms. As I've gone in, the endoscope just touched the side of the entrance, so there's a bit of debris there. So it's slightly blurry just below the suction tip, but when I come out, I can still see what I'm doing. So when I come out next time, I will just give that a wipe. But again, it just got a bit blurry there. So I've just come out, just cleaned the ear now. They have got some antifungal drops, and they brought it with them, so I kind of used that during the procedure as well, just to help bind this wax a little bit together with the debris and the dead skin. And it's an alternative to use. As I said, I avoid using any over-the-counter drops such as olive oil or sodium bicarbonate drops. So just use the antifungal drops and put a couple of drops in, just not too much. And it was just enough to help bind this together. Just trying to loosen it from the roof of the ear canal. There's a bit of skin here that's got caught up in the suction tube, so I'm going to just peel this away, which will help mobilize the rest of the plug. Because the ear is slightly inflamed, it's getting a bit of condensation, so the tip of the endoscope is the coolest part pre-putting the suction tube in. So all the humidity condenses on the lens of the endoscope. But as soon as you go in with a suction probe, because that's vacuuming, it creates kind of cool air in the ear, so the condensation then travels to the suction tip itself, so it kind of helps to demist the tip of the endoscope. Slowly coming away. Fortunately, this came away in a nice plug. There's minimal residue, because sometimes with this consistency, it's a bit like chewing gum actually as well. You can get a bit of residual staining on the eardrum and the ear canal wall, but it's minimal. The right side was slightly different. That ear was a bit more narrow as well. So I'm just trying to lift it out of the anterior and inferior recess. As we approach the eardrum, the ear canal narrows and it widens to the left. In the case of the left ear, it'll be the right on the right side, and it also at the floor of the ear canal. So I've got a good suction grip. I'm not embedding too much with the suction probe. I'm just hovering over the surface, because if I push the suction tip any more into the debris, it will just indent the surface and more than likely block the suction probe. So it's just getting that right level of contact, and it's slowly coming away. I'm just using the endoscope to dilate open the entrance. I can squeeze it through. I'm just using this flicking motion. I don't know if you can see with the suction tip. I'm just kind of flicking from the bottom up just to help release it. And there we are. So it's going to re-enter. You can see nice healthy eardrum. Sort of looking nice and healthy in there. So the right side, the entrance is a bit narrower. It's going to use the left-hand side of the endoscope to dilate open the ear. So there is a bit of wax here, but again, it's just as we get deep in the ear, it's a bit more debris. So I'm just using the left-hand side of the endoscope to stretch open the first bend, but because we're stretching open the first bend using the endoscope, we're right up against the wax. And because the canal is a bit inflamed in this region and it's narrow, as you enter with the suction probe, the information, so the fluid in the inflamed part of the ear canal gets attracted by the suction. So the canal can collapse there. So I'm just using the endoscope to keep it open. Once you're in the ear, as you can see, it's kind of a decent size, but it's a horrible consistency. And this can be typical of fungal involvement. So I'm just going to come away with that piece. So unlike the left ear, this didn't come out in a single large plug. It's kind of a little more delicate work on the eardrum. It's a bit of skin here, so I'm just trying to peel the skin away. And sometimes as you peel the skin away, you can get lucky. The debris is caught up in that skin and then it comes away, but I think the skin just peels away separately here. It might have been a bit of debris that came away. So when you see a consistency like this, sometimes it can be that patients have used like sodium bicarbonate drops or carbamide peroxide, hydrogen peroxide, but it's not. They don't use any drops apart from their prescribed antifungal drops. So just, that's the isthmus. You can see the ear canal narrows here. So we call that an isthmus. An isthmus is just, it's a generic term. It's not just exclusive for, it's not a medical term. It's used in other walks of life, but it kind of just means a narrowing. And in the ear we have two. We have one here, just above the front of the eardrum, about 0.5 centimetre away. And also near the entrance, just past, in between the first and second bend of the ear canal, the cartilage portion. So this second isthmus where we are now, this is the bony part, so this is really sensitive, and it's, you can see it's quite a valley there. There's a prominent V shape. The suction tip, this is a 2 mil, it just about fits in that gap, but there's little wriggle room left to right there. So again, I'm just hovering over, I'm hoping this comes away, but some of the debris is embedded. And again, fungal infections, you tend to find it's closer to the eardrum because it's more warmer there, darker, probably a bit more humidity. And with fungal infections, you can sometimes get thrombosis, so blood clotting of the blood vessels that supply oxygen and nutrients to the eardrum. So you can sometimes get a perforation. This patient hasn't got a perforation. You can see the back portion of the eardrum, the blue tinge. I'm just lifting that. Oh, that was a nice piece that came away. You can see all this. It's kind of like mashed potato. It's the best way I can describe it. It's a horrible consistency. I think I'm possibly using the 16 gauge here because I still, with this, the smaller fine ends, they can quite easily get blocked with this consistency. I want to avoid this 14 gauge if at all possible because it's quite a large suction probe and a bit noisier and there's not much space there. And now that we can see more of the eardrum, the noise levels will increase for the patient. So I think this is a 16 gauge value at the looks of it. Just want to avoid the canal wall to the right. So we will end up seeing a lot more of the eardrum, but it's not going to be crystal. I'm not going to get every little last flake out. of hair there as well. So again, I'm just trying to kiss the surface. I'm just being very cautious because I don't want to poke and prod against the eardrum. So I'm just going to give that area a little break. I'm just going to mop up around the back. There's a bit of skin at the top right as well. So I think the way I've angled the wax, the iCLEARscope, I think I'm going to go for this. I can just tell by the angle. So again, just hoping as I peel the skin away, some of the skin is underneath the debris and it's attached to the eardrum. So as I'm peeling it away, it'll come off the eardrum and debris sitting on the surface of the skin will also come away. Just a bit of debris that got made contact with the lens of the endoscope. So just come out, just giving that a wipe and just going back in. Skin is quite adhesive. I'm having to really pull and stretch to kind of elevate it and take it away from the surface of the canal wall. So that tail end of the skin there, that is now on the eardrum. So I'm not peeling the skin off the eardrum at the moment, just peeling it more on the side walls, but it's attached to some skin deeper. Now this bit was a bit crusted. So when I made, it wasn't mushy. So when I made contact with that region, it was a bit firmer. So this is again on the eardrum, anterior recess, just kissing the surface and coming away. You can see some of it did suction up, but not all of it, and it's just because of the consistency. So there is a limit, so you can start, sometimes you can make it worse because you're just pushing the suction tip against this debris on the eardrum and it's not suctioning and you're just kind of compacting it more and spreading it. Now, hopefully now that I've got all the debris in front of it away, this will slowly migrate away. That's what normally happens with this patient. Again, it's just some in this valley, just want to see if that comes away. It's so mushy though. May have just blocked the suction tube there, so just come out. You see at the entrance there's a bit of dry flaky skin. I'm just going to see if that comes away just to get a better view actually. And because I think when I was entering with the endoscope, some of it was just touching this debris, and a bit on the left, the first bend was just touching the lens. Got a bit of clarinetting there. You may have seen the skin was flapping, so I just come away from that. I'm just going to give it another go, and I managed to just peel it away before the flapping got exaggerated. So this is the tricky bit because it's like soft butter, and when you're gliding with the suction probe, you just don't know where the canal wall is because you don't know how thick this layer is. So I'm angling the suction tip from left to right, so it's not, when I'm gliding, it's kind of following the natural contour of the ear canal. So I can be safe that I'm not going to dig in the side of the suction tip into the canal wall. That would be uncomfortable. So I think I'm going to go for that top bit, the attic region. So this is the bit that was a bit more crusted, a bit more solid, if I remember. But I don't think that suction tip's going to fit in that gap, so I'm going to get a smaller one. So that was probably the 17 gauge, and I'm using the 18 gauge now, or I'm using the 19 gauge now, just because you got the hammer bone. You can see the top part of the hammer bone there, the short process. Don't want to be poking again. The hammer bone's underneath the eardrum, but it's attached to the eardrum, so I don't want to get the suction tip on that. So I just got, I think this is the 19 gauge, so super fine end, and it just fits in the gap. But I don't think I'm going to get much more out. And this is the attic region. So again, sometimes the neck of the malleus is involved there. But I'm kind of happy with that. So some of you guys may not be, but I certainly am, so as a patient. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.